Hello everybody, and welcome to my video presentation for the 12-lead ECG placement guide. My name is Antonia Priximarian, and I hope you learned something today. First things first, what is an ECG? ECG, or electrocardiogram, is a non-invasive yet most valuable diagnostic tool, as it can record the heart's electrical activity as waveforms. When it is interpreted accurately, an ECG can detect and monitor a host of heart conditions, from arrhythmias to coronary heart disease to electrolyte imbalance. So let's go now to the 12-lead ECG. A 12-lead ECG paints a complete picture of the heart's electrical activity by recording information through 12 different perspectives. Think of it as 12 different points of view of an object woven together to create a cohesive story, or the ECG interpretation. These 12 views are collected by placing electrodes or small sticky patches on the chest or precordial, wrists, and ankles. These electrodes are connected to a machine that registers the heart's electrical activity. So, who should have a 12-lead ECG? Well, the main purpose of the 12-lead ECG is to screen patients for possible cardiac ischemia. This can help hospital staff to quickly identify patients who have STEMI, or ST, elevation myocardial infarction, or in other words, a heart attack, and they can then perform appropriate medical intervention based on initial readings. So let's go to the 12-lead ECG electrode placement. To measure the heart's electrical activity accurately, proper electrode placement is crucial. In a 12-lead ECG, there are 12 leads calculated using 10 electrodes. The chest or the precordial electrodes and their placements. So we have 6. We have V1, V2, V3, V4, V5, V6. V1 is placed in the fourth intercostal space on the right sternum. V2 is placed beside it on the fourth intercostal space at the left sternum. V3 is placed midway between V2 and V4. V4 is placed in the fifth intercostal space at the mid-clavicular line. V5 is placed at the anterior axillary line on the same horizontal level as V4. V6 is placed in the mid-axillary line on the same horizontal level as V4 and V5. As you can see, V3 is placed midway between V2 and V4. So when we are placing our chest leads, we must place in firstly our V1, followed by V2, and then our V4, so that we can then place our V3, which is then followed by the V6, so that we can put our V5 in the correct position. Next are the limb or the extremity electrodes. So we have 4: the right arm, the left leg, and the left arm. So RA, or right arm, is placed anywhere between the right shoulder and the right elbow. So this can be placed around the chest area, which is right below the right clavicular bone. Our right leg is placed anywhere below the right torso and above the right ankle. So we can place our RL lead on the right upper quadrant of the abdomen. Our left arm lead is placed anywhere between the left shoulder and the left elbow. So in the chest area, it can be placed below the left clavicular bone. And then our left leg lead can be placed anywhere below the left torso and above the left ankle. So this can be placed above the left upper quadrant of our abdomen. So these are additional notes on the 12-lead ECG placements. As I stated a while ago, the limb leads can also be placed on the upper arms and thighs. However, there should be uniformity in your placement. For example, if you attach one electrode on the right wrist, do not attach the left electrode on the left upper arm. So it should be, if you're going to place it on the wrist, it should be for both sides. If it's going to be on the upper arm, both sides. Below on the chest area, both sides. So for female patients, a good landmark to place your leads V3 to V6 is under the left breast. Do not use nipples as reference points in placing electrodes for both men and women, as these locations can vary from one person to another. Next, we go to the 12 lead groups. A lead is a glimpse of the electrical activity of the heart from a particular angle. Put simply, a lead is like perspective. In 12 lead ECG, there are 10 electrodes, but they provide 12 different perspectives of the heart's activity using different angles through two electrical planes, vertical and the horizontal planes. So our vertical planes are the frontal leads. By using four lead electrodes, you get six frontal leads that provide information about the heart's vertical plane. This is your lead 1, lead 2, lead 3, your augmented vector right or AVR, your augmented vector left or AVL, and your augmented vector foot or your AVF. Leads 1, 2, and 3 require a negative and positive electrode bipolarity for monitoring. On the other hand, the augmented leads AVR, AVL, and AVF are unipolar and requires only a positive electrode for monitoring. Next, we go to Einthoven's triangle. So the Einthoven's triangle explains why there are six frontal leads and where there are only just four limb electrodes. The principle behind Einthoven's triangle describes how electrodes RA, LA, and LL do not only record the electrical activity of the heart in relation to themselves through the AVR, AVL, and AVF leads. They also correspond with each other to form leads 1 or the right arm to left arm, lead 2, right arm to left leg, and lead 3, left leg to left arm. As a result, they form a unilateral triangle. Hence, it's called the Einthoven triangle, named after the inventor of the first practical ECG, Willem Einthoven. Keep in mind that the right leg is neutral, or this is also known as your point zero where the electrical current is measured. RL does not come up in ECG readings and is considered as a grounding lead that helps minimize ECG artifacts. Next are your horizontal plane or your transverse leads. By using six chest electrodes, you get six transverse leads that provide information about the heart's horizontal plane. V1, V2, V3, V4, V5, and V6. Like the augmented leads, the transverse leads are unipolar and requires only a positive electrode. The negative pole of all six leads is found at the center of the heart. This is calculated with the ECG. Next, we go to the preparation and the application. So first is your patient's positioning for a 12-lead ECG placement. You must ensure that electronic devices such as smartphones are removed from the patient. These devices can produce artifact or interferences and it can cause a problem with the readings. Place the patient in a supine or a semi-fowler position. So when we say semi-fowler position, this is a position in which a patient, usually in the hospital or nursing home, is lying on their back with the head and torso raised between 15 and 45 degrees. The most frequently used bed angle for this position is 30 degrees. This position can be used when the patient faces difficulty of breathing or is undergoing breathing treatments and when drainage occurs after an abdominoplasty. Due to the positioning, it is a preferred position during childbirth as well. So if that's easier to visualize, so when a mother is sitting on a chair and then inclined between 15 and 45 degrees. So you have place the patient in that position or in a supine. However, if both positions are impossible, you can perform the ECG with the patient in a more elevated position. With arms lying flat on the side, ask the patient to relax the shoulders and keep the legs uncrossed. However, if the patient does not fit comfortably on the bed or exam table due to its size, you may ask them to cross their arms on their stomach to reduce muscle tension and movement. Unless you're performing a stress ECG test, ask the patient to lie still and quietly until the test is done. So how do we reduce significant artifact or interference? A slight ECG artifact is not uncommon. However, you can reduce this further through the following. Switch off non-essential electrical devices and equipment within the vicinity if possible. Check for cable loops and avoid running cables adjacent to metallic objects as they can affect the signal. Inspect wires and cables for cracks or breaks. Replace them as needed. If possible, use surge suppressors with the power supply. Ensure that filters and preamplifiers are appropriately adjusted. Ensure secure connection between the patient and the ECG device. Double check for gaps between the connectors. Skin preparation. The skin should be dry, hairless, and oil-free. Shave hair that can possibly impede electrode placement. Like the electrode should have full contact with the patient's skin. So when shaving the hair, obviously you have to ask for permission first, but this is a necessary thing to do as it can help for better electrode adhesion and reduce interferences. Another way to improve your electrode adhesion as well as promote oil-free skin, you can rub the area with an alcohol prep pad or a gauze pad with benzoin tincture. Reduce electrical resistance minus the skin redness with 5 to 10 gentle strokes. This will help ensure that the heart's electrical signals are transmitted to the electrodes. Promote an environment that prevents the patient from sweating profusely. For the electrode application, exact placement of each electrode on the patient is important as incorrect placement can lead to false or misleading diagnosis. Make sure the electrode conducting gel is fresh and adequately moist. A dry electrode with inadequate gel reduces the conduction of the ECG signal. Often, the electrode gel dry out is a result of incorrect storage. Store electrodes as instructed by the manufacturer and do not remove from their pouch until they're ready for use. Do not place electrodes on skin over bones, incisions, irritated skin, and body parts where there is lots of possible muscle movement. Use electrodes of the same brand as using different brands with dissimilar composition can hinder an accurate ECG trace. So there are other ECG variations apart from the standard 12-lead ECG. Variants include the 3-lead ECG and the 5-lead ECG. So the 3-lead ECG uses 3 electrodes that are labeled white, black, and red. However, these colors are not universal as 2 coloring standards exist for the ECG. The 3 leads monitor rhythm monitoring but doesn't reveal sufficient information on SC elevation activity. A 5-lead ECG uses 4 limb leads and 1 chest lead. It helps improve ST elevation readings, but it's still inferior to the 12-lead ECG. I mentioned a while ago that the colors are not universal as there are 2 coloring standards for the ECG. Currently, there are two for the coloring standards, the IEC system and the HAS system. IEC, or the International Electrotechnical Commission, and AHA, or the American Heart Association system. So for the AHA, RA is white, LA is black, RL is green, LL is red. V1 can be brown or red, V2 can be brown or yellow, V3 can be brown or green, V4 can be brown or blue, V5 can be brown or orange, V6 can be brown or purple. For the IEC, the inscription will be R for RA, which is red, L for LA, which is yellow, RL, which is labeled N in the IEC for black. F is your LL or green. C1 is your V1, white or red. C2 is white or yellow. C3 is white or green. C4 is white or brown. C5 is white or black. C6 is white or purple. If you are using the American Heart Association system, you can use this mnemonic to easily recall limb electrode placement. So smoke over fire, meaning your black lead is above your red lead, and your snow over grass or your white lead is above your green lead. Some more nice to know or ECG best practices. Always protect the patient's privacy and dignity by draping with a sheet to minimize exposure. Lead placement and patient positioning should be the same for subsequent ECGs on any individual patient. During the procedure, record any clinical signs, example chest pain in the notes or on the ECG tracing itself. Next, we go to the procedure. This is a step-by-step guide on what you should do. After you take your materials or after you prepare your materials, you must wash or sanitize your hands, greet the patient, and introduce yourself. After that, you must ask for the patient's identity while explaining the procedure to them and gaining their consent to proceed. Clarify whether the patient knows why the test is being performed, such as for chest pain. Ensure that the patient is comfortable for this test, and the patient must have their top off, so offer a chaperone if they want. For the ECG pads to stick, there must be good contact with the skin. Therefore, ensure there is nothing which could prevent this, for example, shaving off the hair or wiping off any cream or lotion. Input the patient's data into the machine correctly. thus ensuring the correct details are printed on the ECG. Although this is called a 12-lead ECG, as stated a while ago, you would only need 10 sticky pads, where there are only 4 limb leads and 6 chest leads. Quick recall, your leads will be placed in the right wrist or shoulder, left wrist or shoulder, right ankle laterally, left ankle laterally. Your V1 is in the fourth intercostal space at the right sternal edge. V2 is placed in the fourth intercostal space at the left sternal edge. V4 is placed in the fifth intercostal space in the midclavicular line, while V3 is placed between your V2 and V4. Your V5 is horizontal to the V4 in the anterior axillary line, and your V6 is horizontal to V4 and V5 in the mid-axillary line. Next, you must attach the leads to the pads. Once all the leads are attached, ask the patient to lie as still as possible. Record the reading and print a copy. If the patient had any chest pain at the time of recording, you should record this on the ECG. Afterwards, you may disconnect the leads from the pads and allow the patient to remove the pads themselves or offer assistance if needed. Offer tissue as the pads are quite stiff because of the gel. After that, allow the patient to rest, and obviously you have to thank them for the procedure. Next, I'll be presenting a short video detailing what should be done and how to conduct your ECG.
So, my name is Dr. Gill, and I've been asked to do an ECG of yourself today. Before we start, could you please confirm your name and date of birth?
Mickey Mouse, 22nd of March 1997.
Super. So before we go any further, could we just check, do you have any problems with your heart?
No.
Thank you. So what I'm going to do, I'm going to input that information into the ECG, but as well as that, I need your height, if you know it.
178 centimetres.
Perfect. And your weight?
65 kilograms.
Superb. Oh, and your age was?
24.
Super. Right. Once we've inputted the information, we need to make sure that we're gelling our hands. And if you could please take off your shirt and lie back on the bed. It's quite important when you're doing the ECG that you've got the machine on a trolley with wheels to it, so you can bring it closer to the patient if you find that your leads aren't quite reaching long enough. So we're going to start off with our limb leads. So we're going to move our chest leads across the patient to start off with. We're going to move our leg leads down towards the bottom of the patient, and we're going to bring our arm leads to the top. So let's just move those over there. Different ECGs will have slightly different electrodes. These electrodes, you need to apply a slight extension to each before you apply them to the patient. Because it's a button end to it, if you were to apply this afterwards, it would be quite uncomfortable for the patient. So with your ECG electrodes placed, we need to apply them to the patient. So in terms of our first leads, we're going to place on the arms. So we want to make sure that they're away from any bony prominences and that we're applying them directly over the skin without any crossovers of the arms and legs. In terms of going down on the legs, we're going to apply them over the inside of the ankle. However, they're not absolute in terms of the positioning. And what I mean by that is as long as your ECG leads are on the limbs and not over bony prominences, that is acceptable. You'll see certain ECGs, for example, when we're doing an exercise ECG, will place the leads at the shoulders and over the mid-thighs. This is in order to reduce the risk of them coming off whilst the patient is running on the treadmill. In terms of the 6 chest leads, the precordial leads, we need to find the manubrial sternal angle. This is associated with the second intercostal space directly below it. We then need to find the 3rd and the 4th on the right side of the sternal border. This is where we're going to place the first electrode, and we're going to make sure that if we've got circular ones like this, that the electroconductive material is going vertically. We're then going to do the same again, manubrial sternal angle, to the second intercostal space, 3rd intercostal space, 4th intercostal space, to place the second electrode. We're then going to jump to the 4th electrode, and that's going in the mid-clavicular line in the 5th intercostal space. Now the reason why we've taken the 4th electrode at that point is because the third electrode will go again in the fifth intercostal space, but between the second and the fourth electrode. We're going to do similar again and take the sixth electrode and place it in the mid-axillary line on the fifth intercostal space. And finally, we're going to go back to V5, going between the sixth and the fourth lead, again in the fifth intercostal space. This will then allow us to attach our wiring to our precordial electrodes in order to get a horizontal or transverse view of the heart. With our electrodes in place, we then want to attach the leads. And thankfully, these are colour-coded when it comes to the limb leads. So we're going to put red to the right arm, yellow to the left arm, green to the left leg, and black to the right leg, using the nice and simple phrase or mnemonic, ride your green bike. And these will be applied in a clockwise fashion. So in terms of the limb leads, as said, we're going to go for red first for ride, then yellow for your, then green on the left leg. We're going to have our black lead, that's going to go to the right leg. We then want to apply our chest leads, which are colour-coded but are also numbered. So we're going to start off with our, obviously, V1. Then we have V2. V3. V4. V5. And V6. So this should hopefully give us a working ECG. Let's have a look here. So with our leads attached, we're confirming that we've got a good trace going through, and we're making sure that we're happy with the speed here set at 25 millimeters per second. Once we can see we've got a good trace and nothing here looks untoward, by that I mean any evidence that we've got leads the wrong way round, then we're going to hit start to record. So we're going to get 10 seconds of recording of the ECG. And then we're going to look at the file to make sure that there's no issues here. So again, we're confirming we've got 52 beats a minute. There's no obvious abnormalities here. Now we can see if the automated system has given us a diagnosis. Here we've got normal sinus rhythm and a normal ECG, and I would actually agree with that. However, it's always best to make sure you interpret these yourself because the machine can be slightly problematic. Once we've unwired the patient, we can allow the patient to remove their electrodes themselves. However, we're making sure that we're keeping hold of the attachments and binning in medical waste the actual attachment to the chest. So if you'd be kind enough to take off the electrodes. And obviously, once we've completed their examination, we need to thank the patient and make sure that we return their shirt to them. So thank you for that. Any questions to myself after that?
No. Thank
Super.
you.
Well, thank you very much for your time. Well, I hope that overview of the ECG was useful for you, so you now understand where it is you're placing the leads and why some of those lead placements are important, such as avoiding any bony prominences, but conversely, why there are variations between different disciplines. For example, with sports medicine, as said, applying leads to the thighs and the shoulders may be done to improve the signals coming through, as opposed to if they're on the very edges of the limbs, which we might do with a supine patient. Well, if we try to get the patient to run like that, we're going to get a very disrupted signal.
In conclusion, after you perform your ECG, usually you would do electrocardiography interpretation, so you should be familiar with the most common ECG findings, which are typically your sinus rhythm, atrial fibrillation or AF, ST elevation or STEMI. However, it is also good to know what ventricular fibrillation and ventricular tachycardia looks like, as this is important for advanced life support skills. Thank you so much for watching and listening, and I hope you learned something today.